Good morning, respected Emeritus Chairman Sir, respected VC Sir, respected Pro VC Sir, respected Medical Director Sir, and dignitaries, my uh, fellow faculty members, and dear students. It is my privilege to present combined clinical rounds of the Department of Anaesthesiology today. The Department of Anaesthesiology was established in the year 2000, coinciding with the inception of this medical institute. The first batch of postgraduate students was inducted in 2007, initially with the intake of 5 students per year, which progressively increased to 15, and at present we have an annual intake of 32 students. It's a matter of immense pride for the department that all 32 seats, including management quota seats, were filled during the second round of NEET PG itself, reflecting strong academic reputation of our department. Presently, we have got a strength of 79 postgraduate students. The department is supported by a strong faculty of 27 members, including professors, associate professors, assistant professors, and SR. It's a matter of great pride that in our department includes distinguished personalities in academic leadership and administration. We are honored to have former Vice Chancellor of our Institute, Dr. Sudhir Sachdev, as professor in our department. Dr. Avnish Mahatma is editor of reputed national and international editor of journals of anesthesia, and Dr. R.C. Gupta being formal medical superintendent. Our students have consistently brought laurels and gold medals to at various national and international forums. We have a structured academic program which includes seminar, didactic lectures, CMEs, workshops, and we are actively organizing hands-on workshops and simulator-based training on Phantom. Our faculty members are invited as a resource person for conduction of hands-on workshops at various national and international conferences. This is the data showing last 3-year workshops which are conducted. We have a vast scope of anesthesia as shown in this diagram. We have got 21 state-of-the-art operation theaters, including modular operation theaters with advanced workstation and monitors and other equipments including BIS, TAG, fiber optic videoscope, neuromuscular monitoring, to name a few. We also have non-invasive hemodynamic monitoring of cardiac output. As a tertiary referral center, we routinely manage patients with complex comorbidities, and we conduct who are highly compromised in cardiac, renal, and hepatic functions, yet consistently achieve safe and successful anesthesia outcome. Another feather in the cap of Department of Anesthesia is successful conduction of robotic surgery, which started in June 2024, and so far 314 successful cases have been done so far. Beyond operation theatre, our department plays a crucial role in non-operating room anesthesia or NORA services. We provide anesthesia across approximately 6 NORA locations including ERCP suites, PET scans, MRI suites, radiotherapy units and cath labs. Our highly skilled anesthesia team caters to the patient across entire age spectrum from neonate to centenarians. Approximately 60 to 80 anesthesia cases are conducted per day. We have got 2 dedicated PSC rooms, dedicated post-anesthesia care unit and well-established pain unit. This is the data showing the number of cases conducted under GA, which are progressively increasing in last 3 years. Notably, we are amongst the very few institute in North India offering comprehensive range of neurological block, basic peripheral nerve block and advanced peripheral nerve block on routine basis. In conclusion, a Department of Anesthesia continues to strive for clinical excellence, academics and patient safety, upholding the highest standard of anesthesia care. Now I invite Dr. Pragya to present today's case.
Thank you, ma'am. Good morning, Emeritus Chairperson, sir, Vice Chancellor, sir, Pro VC, sir, Chief Advisor to Chairperson, sir, Medical Director, sir, faculty, and my dear colleagues. Today, I, Pragya Jain, third-year postgraduate student from the Department of Anaesthesiology, stand before you all to present combined clinical round on the topic, a silent saboteur in the body's main highway. I'd like to begin with the reason why we are choosing this topic. We are choosing this topic as this case emphasizes that vigilant monitoring and appropriate decision making by multidisciplinary team, especially during perioperative period, can tide out patient during critical stages of complex surgery. Now I would like to call Dr. Gautham Mohan from Department of HPB Surgery and Liver Transplantation to enunciate details of this case.
Good morning everyone, I am Dr. Gautham Mohan, third year resident, Department of HPB Surgery and Liver Transplant. A 47-year-old male was present to our OPD who was initially evaluated with left inguinal hernia and was subsequently found to have a inferior vena cava tumor on further imaging. His chief complaint was right upper abdominal discomfort for 1 month. He had no history of jaundice, abdominal distension, no history of any anorexia, weight loss or fever, no history of dyspnea, orthopnea, and no flank pain or hematuria. He had no significant comorbidities and any prior surgical history. On examination, he was comfortable, cooperative, and oriented with a normal vitals and a BMI of 31.6 kg per meter square. There were no pallor, clubbing, icterus, or cyanosis, but he had a bilateral pitting edema of the lower limbs. Periabdominal examination, on inspection, there were no dilated superficial veins, no visible abdominal mass, and there was a left inguinal hernia noted. Palpatory findings, there were no organomegaly, no other lump palpable, and no ascites. We further evaluated him with a contrast enhanced CT. Now I call upon Dr. Sharbeen to discuss regarding the CT findings.
Good morning, respected dignitaries. I, Dr. Sharbeen, a third-year radiology resident, will be discussing the radiological features of this case under the guidance of Dr. Swati Joshi ma'am. A 47-year-old male patient was referred from the hepatosurgery department to us for a triple phase CT scan of abdomen. These are the axial CT images. These are the axial CT images in venous phase, in which we can see that the hepatic segment of the IVC appears dilated and filled with heterogeneous appearing mass lesion, along with contiguous involvement of the middle hepatic vein. There is also partial intraluminal thrombosis in the right hepatic vein. There is loss of fat planes with the adjacent liver parenchyma involving the caudate lobe and with the right diaphragmatic crus. The lesion measures approximately 5.6 by 5.6 by 6 centimeter in size. These are the coronal images, coronal and CT images, sagittal CT images in venous phase, in which we can see that the cavo-atrial junction appears patent and rest of the supra and infrarenal IVC appears patent. The lesion measures approximately 6 centimeter in length. These are the comparative volume rendered 3D images of normal IVC and in our patient's IVC, in which we can see that a tumor is seen in the hepatic segment of IVC and rest of the supra and infrarenal IVC appears patent, along with the cavo-atrial junction and bilateral renal veins appears normal. So to sum up our findings, a large heterogeneous appearing mass lesion is seen involving hepatic segment of IVC with contiguous extension into the adjacent middle hepatic vein. Partial intraluminal thrombosis is also seen in adjacent right hepatic vein. There is loss of fat planes with the adjacent surrounding liver, including the caudate lobe, and with the right diaphragmatic crus, likely malignant etiology, leiomyosarcoma of IVC origin. Now I would like to call Dr. Gautham to carry this case forward. Thank you.
As per the CT report, we have a retrohepatic IVC tumor with partial thrombosis of the hepatic vein. This schematic diagram explains the tumor location, with the actual location of the tumor being posterior to the liver and within the IVC. Why surgery in this patient? Because the progressive IVC obstruction can lead to ascites, lymphedema and venous congestion. There is a significant risk of acute hepatic venous outflow compromise in this patient, resulting in liver congestion and potential liver failure. Many of these tumors have malignant potential or proven malignancy, where the surgical resection offers the only chance of cure. The operative intervention also prevents the life-threatening complications such as tumor embolism, and in carefully selected patients, surgery allows the complete tumor resection with acceptable vascular reconstruction while preserving the hepatic venous drainage. The surgical plan begins with a meticulous pre-operative planning. First, we define the extent of the retrohepatic IVC and the involvement and the relationship of the hepatic veins, because it helps in the planning of resection and reconstruction strategy. We then assess the need for the total hepatic vascular exclusion, that is a surgical technique in which both the inflow being the portal vein and hepatic artery, and the outflow, that is the hepatic vein or the IVC, both are temporarily clamped for arresting the blood flow to the liver, which creates the bloodless field for complex liver resection as well as for the retrohepatic IVC surgery. The evaluation of an established collateral venous circulation is also important, because we don't want to injure it during the procedure, and a baseline LFT and an RFT is required, which helps to determine or predict the tolerance of the vascular clamping. Total hepatic vascular exclusion can lead to coagulopathy during the procedure, so adequate blood and blood products are arranged prior to the procedure to ensure a safe resection and timely reconstruction by arranging adequate vascular grafts. Now I call upon Dr. Pragya to discuss regarding the pre-anesthetic challenges.
Thank you, Dr. Gautam. Carrying this case forward, the patient was sent to us from the Department of HPB Surgery and Liver Transplantation with a diagnosis of large mass of retrohepatic IVC, and the proposed surgery of this patient was total vascular exclusion and en-bloc tumor resection, followed by prosthetic IVC reconstruction and reimplantation of the liver outflow. The patient was comfortable, conscious, cooperative, and oriented to time, place, and person, with weight 86 kgs, height 164 cm, BMI 31.6 kg per meter square, and NYHA grading of physical examination as 2. Upon examination, patient's history was taken and vital parameters were recorded. His pulse was 92 beats per minute, which was regular with good volume. BP 130 by 80 mm Hg measured on left upper limb brachial artery in sitting position. Respiratory rate of 14 breaths per minute of abdominothoracic pattern and saturation of 99% on room air. The only significant finding was bilateral pitting edema of lower limbs. The remainder of the general and systemic examination was unremarkable. Airway assessment is an integral part of any pre-anesthetic checkup. Patient's airway was assessed using modified Mallampati grading, which was 2 for this patient, and measuring thyromental distance, which was more than 6.5 cm for this patient. That means that his features were consistent with that of a normal airway, with no predictors of difficult mask ventilation or tracheal intubation. Pre-operative investigations of complete blood count, renal function test, electrolytes, liver function test, and coagulation profile were done, and all were within normal limits except APTT, which was slightly raised. Electrocardiogram, chest X-ray, 2D echo were done, and all were normal. CET-CT findings were elaborated as by Dr. Sharbeen. Patient's blood group was B negative, a rare group. Certain risk stratification scores are used in pre-anesthetic checkup for physical examination, one of which is American Society of Anaesthesiology or ASA grading, which was 2 for this patient. Another score that we use is metabolic equivalent of task or MET scoring, which was more than 4 for this patient, since this patient had no dyspnea upon exertion or climbing stairs. Now, what anesthetic consideration makes this case different from others? This case would require prolonged, repeated, intermittent IVC clamping and release. IVC clamping leads to abrupt loss of venous return due to decreased preload and decreased end diastolic volume. This leads to severely decreased low cardiac output and marked hypotension, along with metabolic derangements, lactic acidosis, and acidemia. IVC unclamping would lead to ischemia, reperfusion injury, causing sudden hemodynamic instability due to washout of ischemic metabolites and oxidative stress, which may precipitate an embolic event. Repeated clamping and unclamping in a prolonged operative duration could worsen hemodynamic changes and increase the risk of massive hemorrhage and coagulopathy. This could cause decrease in hemoglobin concentration, cardiac output, and microcirculatory failure. This could lead to decreased renal, hepatic, and cerebral perfusion due to impaired oxygen delivery. Because of the uniqueness of this case, special anesthetic considerations were taken into account. Since this surgery would require a multi-department coordination, a multidisciplinary pre-operative planning was done. Anticipating sudden and major blood loss, cross-matching, blood grouping, intimation to blood bank, and activation of massive blood transfusion protocol when needed was ensured, with arrangement of adequate number of blood and blood products. Equipments like intra-aortic balloon pump console and cardiac pulmonary bypass were made available pre-operatively. Availability of thromboelastogram was ensured for factor-based replacement when needed. Transesophageal echocardiography, which would serve as a window to detect an event of pulmonary embolism and monitor cardiac function, was made available preoperatively. In view of anticipatory hemodynamic shifts, HPI cardiac output monitor was made available. Prolonged surgery predisposes to hypothermia. Therefore, equipment like rapid infusion pump and technique like forced rewarming through body and blood warmer and availability of warm IV fluids were ensured preoperatively. For this prolonged surgery, bispectral index monitoring was made available to monitor the depth of anesthesia. In anticipation of potential perioperative emergencies, a fully equipped crash cart with all the emergency drugs and a comprehensive airway cart for any unanticipatory airway complication was prepared prior to induction. On arrival to operation theatre, all sign-in protocols were done and baseline hemodynamics were attached. Advanced monitoring and vascular access was done for advanced hemodynamic monitoring and continuous blood pressure monitoring under local anesthesia, with placement of left radial arterial line, large bore central venous catheter sheet of 8.5 French and 7.5 French 13 cm triple lumen central line was placed in the right internal jugular vein, which could also serve as a portal for rapid fluid, blood products and drug administration in an event of aspiration of pulmonary emboli if needed, or for insertion of PA catheter if needed. After attaching all the advanced hemodynamic monitoring, patient was induced using general anesthesia. Patient was pre-oxygenated at 100% oxygen for 3 minutes and then pre-medication injection midazolam and injection fentanyl was given. Patient was induced using injection propofol and injection atracurium was given to ensure neuromuscular blockade, followed by which cupped endotracheal tube was placed orally and low flow lung protective ventilation on PRVC mode was initiated. Maintenance of general anesthesia was done using inhalation agent isoflurane and was monitored using bispectral index. Now I would like to call upon stage Dr. Gautham Mohan from HPB Surgery and Liver Transplantation to take this case forward.
Thank you, Dr. Pragya. Now let's discuss the surgical challenges and the management in our case. Why retrohepatic IVC tumors are particularly challenging? Because of the highly complex regional anatomy, as the tumor is located behind the liver, which requires mobilization of the liver to reach up to the tumor for resection. Next, the tumor is located at the position where the right hepatic vein, middle hepatic vein and the left hepatic vein opens into the IVC, and it requires the disconnection of the hepatic vein for tumor excision and later requiring reimplantation of the hepatic veins. Then lies the adjacent structure to the IVC, that are the aorta and the renal veins, which needs to be safeguarded because injury to these structures can lead to massive bleeding. We also have to keep in mind the hepatic venous outflow compromise that can occur during the surgery, which can lead to the congestion of the liver and hepatocellular ischemia, necrosis, and which can lead to the acute hepatic failure. As a result, safe resection requires meticulous planning, advanced vascular control technique like total hepatic venous exclusion, and the ability to perform complex venous reconstruction when necessary. The tumor assessment begins with the precise delineation of the level and the longitudinal extent of the retrohepatic IVC involvement. Its relationship to the hepatic and the renal veins is carefully evaluated to determine the resectability and the reconstruction strategy, and the degree of luminal encroachment or complete occlusion is assessed as it influences the hemodynamics and the surgical planning. The assessment of collateral venous circulation is crucial to predict the tolerance to the IVC clamping and guide an operative decision making. The resection strategy is planned accordingly, aiming for an en bloc excision of the tumor along with the involved IVC segment while preserving the uninvolved hepatic veins whenever possible. If the hepatic veins are involved, it needs to be resected and reconstructed. And with keeping in mind to minimize the duration of hepatic ischemia. The reconstruction options include primary repair and patch cavoplasty or interposition grafting depending upon the circumference of the IVC involved. In selected complex cases, total hepatic vascular exclusion and in vivo or ex vivo liver resection may be required to achieve a complete oncological clearance. This schematic illustrates the surgical plan used in our case, that is total hepatic vascular exclusion for excision of a retrohepatic IVC tumor. The hepatic inflow is controlled by clamping the portal vein and the hepatic artery, and the venous outflow is arrested by supra and infrahepatic IVC clamping. This allows safe exposure of the retrohepatic IVC and precise tumor resection while protecting the hepatic veins. Now let's see the intraoperative findings. Laparotomy was done and there was no dissemination of the tumor. The ligamentous attachment of the liver were divided, and we can see the right lobe of the liver is being retracted and the inferior hepatic vein is being divided. The infrahepatic IVC is being looped and posteriorly dissected for free mobilization of the IVC. Similarly, the suprahepatic IVC is also being looped in this. The tumor was felt at the diaphragmatic opening. Now we can see the inflow of the liver is being looped for the Pringles maneuver. While looping this, we include the portal vein, the hepatic artery and the bile duct in it. Now the sternotomy is performed with the help of CTVS team, and the supradiaphragmatic portion of the IVC is looped here. Now the supra and infrahepatic IVC is being clamped, and with Pringles applied we achieved total hepatic vascular exclusion, and longitudinal incision was made on the IVC and it was extended superiorly and inferiorly. Carefully the tumor was visualized and the hepatic venous attachment to the IVC was disconnected, and the tumor was carefully dissected out and removed. Now we can see a disconnected hepatic venous outflow from the liver, and a careful thrombectomy was performed from the right hepatic orifice where there was thrombus found intraoperatively. Similarly, the thrombus was found in the middle hepatic and left hepatic vein orifices. It was flushed with heparinase saline to confirm the thrombus was completely removed, and we can see the free flow of blood. Now a neo IVC graft is used for reconstruction of the resected IVC. It is being sutured superior to the infradiaphragmatic IVC and inferiorly to the suprarenal IVC. After suturing, the clamps were removed and the IVC circulation was re-established. Now you can see the MSV and LSV plasty is being done in this case. This is the most surgically challenging step in our procedure, that is re-implantation of the hepatic venous outflow. The right hepatic vein is being re-implanted to the neo IVC by side clamping the IVC, and in similar fashion the left and the middle hepatic veins were also re-implanted to our neo IVC. After this, the hemostasis was confirmed and a intraoperative Doppler study was done to show a good hepatic venous outflow in this case. Laparotomy and sternotomy was closed after keeping the drain. The patient was kept intubated and shifted to ICU on inotropic support. Now I call upon Dr. Devanshi to discuss regarding the intraoperative challenges in this case.
Thank you, Dr. Gautham. Good morning, respected dignitaries and my fellow colleagues. I am here to discuss how we anticipated and managed the specific challenges of this case, beginning with the use of transesophageal echocardiography. It is a specialized 2D echocardiogram which gives us the real-time assessment of cardiac filling and function. It was introduced in the patient's esophagus after intubation per oral route and was kept throughout the surgery. It guided hemodynamic monitoring by allowing dynamic assessment of cardiac contractility. In our case, it additionally helped in real-time visualization of the retrohepatic IVC to rule out any embolic event during tumor manipulation, dissection, and clamping of IVC. Continuous TEE guidance allowed us to anticipate hemodynamic fluctuations rather than respond to it after a fall in blood pressure. The intraoperative monitoring of depth of anesthesia was achieved using the bispectral index or the BIS monitor, the value of which were kept between 40 and 60 as required for general anesthesia. It is kept 55 in this monitor. Rapid decline in BIS values below 40 despite adequate oxygenation suggested cerebral ischemia, hypoperfusion. This is a graphical representation of the intraoperative hemodynamic data. As we can see, the surgery lasted almost 12 hours from 8 am till 8 pm, with the period from 11 am till 4 pm being the most dynamic 5 hours of the surgery, encompassing tumor manipulation, IVC clamping, vascular reconstruction, and subsequent unclamping of IVC. Hemodynamic changes of ischemia reperfusion can be appreciated here. At 1:30 pm, the cardiac index values were less than 1.2 liter per minute per meter square, which is less than 50% of the normal value, causing subsequent rise in heart rate touching up to 160 beats per minute. Further discussing this highlighted area, this chart justifies all the advanced hemodynamic devices used in this case. This table explains the goal-directed management for hemodynamic derangements using vital signs, invasive parameters, arterial tone, urine output, and TEE findings. In the initial phase, despite blood loss and fall in hemoglobin, the cardiac index was maintained. Further blood loss triggered compensatory tachycardia and rising dynamic preload indices, suggestive of evolving hypovolemia. The TEE at this stage showed reduced ventricular filling with preserved myocardial contractility, confirming hypovolemia. Hence, judicious packed red blood cell transfusion and volume replacement were instituted. As the surgical stress increased and
कितने unit blood दिए डॉक्टर? How many units?
We have total 7 PRBC was transfused throughout the operation. As surgical stress increased and venous return compromised, urine output began to decline, reflecting reduced renal perfusion. Interventions were then escalated using vasopressors as suggested by the SVV-PPV ratio. The final row reflects the target physiological range we aimed to maintain once vascular reconstruction was complete. The hemodynamic management during IVC clamping and unclamping was achieved by early initiation of vasopressors and inotropes, and they were up-titrated proactively to maintain adequate mean arterial pressure. The TEE assessed ventricular filling and contractility. Fluids were administered judiciously and blood product replacement was guided by TEG and ABG. Cardiopulmonary bypass was kept ready in case required. Thromboelastography provides a real-time functional assessment of clot formation and stability. We are fortunate to have this point-of-care facility at our institute. The initial tag at around 8 am was within normal limits. As the surgery progressed at around 10:30 am, the prolongation of the clot initiation time, as indicated by the increase in the R time, and reduced clot strength, as indicated by the decrease in the maximum amplitude, indicated a combined coagulation factor deficiency and platelet dysfunction. This change coincided with IVC clamping, likely resulting in reduced hepatic flow and impaired synthesis or delivery of the coagulation factors. In response to it, targeted blood component therapy was initiated with transfusion of fresh frozen plasma, cryoprecipitate, and random donor platelets. At 12:40 pm, decrease in the lysis time indicated early fibrinolysis, for which tranexamic acid was given. At around 3 pm, TEC findings indicated transfusion of fresh frozen plasma, cryoprecipitate, and random donor platelets. Subsequent tags showed normalization of clot kinetics. Point-of-care serial arterial blood gas analysis was used to detect and correct evolving hematological and metabolic derangements. Early intraoperative gas exchange and acid-base status was within normal limits. As the surgery progressed and blood loss increased, metabolic acidosis developed, reflected by falling pH, rising lactate levels, and declining hemoglobin levels. These changes correlated with periods of reduced venous return and increased transfusion requirement. Rising lactate levels and worsening base deficit reflected impaired tissue perfusion, prompting correction of hemodynamics. The electrolyte abnormalities, particularly potassium and calcium fluctuations, were anticipated and corrected promptly to maintain myocardial contractility. With restoration of hemodynamic stability and completion of vascular reconstruction, acid-base status and lactate levels gradually improved. To put the intraoperative events into perspective, this slide summarizes the overall duration of surgery, which was around 12 hours, and the magnitude of blood loss. The maximum allowable blood loss calculated for this patient in the preoperative period was around 3 liters, but the total estimated blood loss calculated at the end of surgery was around 7 liters. These numbers reflect the physiological stress encountered during the procedure and provide context for the monitoring strategies and interventions discussed in the preceding slides. Despite the transfusion of 7 units of packed red blood cells, 4 units of fresh frozen plasma, and 10 units of platelets, we remained ahead of developing coagulopathy through the use of advanced point-of-care hemodynamic monitoring and timely and targeted interventions. Following achievement of surgical hemostasis and completion of sternotomy closure, venous return was restored and hemodynamic parameters showed progressive improvement. This allowed gradual down titration of vasopressor support while maintaining adequate perfusion. Post-operatively, the patient was shifted to ICU, intubated and sedated for elective ventilation and on noradrenaline support. On post-operative day 1, the patient was extubated. Low molecular weight heparin was started for thromboprophylaxis. On post-operative day 2, a good clinical response allowed tapering and eventual stopping of vasopressor support. By post-operative day 3, the patient was ambulatory, and by post-operative day 5, the patient was shifted out of the ICU. By post-operative day 10, all the remaining drains were removed and the patient was discharged in stable condition on post-operative day 10. I would now like to call upon Dr. Himaxi from the Department of Onco Pathology to discuss the specimen sent to the laboratory.
Good morning all the dignitaries and my fellow colleagues. Myself Dr. Himaxi Rathore, SR1 in Department of Oncopathology. I am demonstrating histopathological finding of this case under the guidance of Dr. Neha Sethi ma'am. We received specimen of inferior vena cava mass in our department. On gross examination, we can see tumor measuring 5.5 by 5.5 by 5 cm, which is partially infiltrating inferior vena cava wall. Cut surface of tumor is solid, homogeneous, grey-white and appearance of bulb. Now coming to microscopic finding, Low power view of tumor showing intersecting fascicles of spindle cell. Here we can see tumor infiltrating partially into inferior vena cava wall, and high power view showing moderate pleomorphism, high NC ratio, and individual tumor cells exhibiting moderate amount of pleomorphism, high NC ratio, eosinophilic cytoplasm, cigar blunt-ended nuclei, and abnormal mitosis. Now coming to immunohistochemistry finding. Desmin showing diffuse cytoplasmic positivity which denotes muscle origin. H. Kaldeshmon showing diffuse cytoplasmic positivity which denotes smooth muscle differentiation, and Ki67 being 25 to 30% positivity which is nuclear positivity. So our final microscopic report was procedure inferior vena cava mass, wide local excision, tumor focality was unifocal, FNC LCC grade which is grading system for soft tissue sarcoma which includes following 3 parameters. Tumor differentiation was given score 1, necrosis present less than 50% was given score 1, mitotic activity 15 to 16 per 10 high power field which was given score 2, so total score 4 coming under grade 2. Tumor extent was tumor infiltrating vessel wall and all resection margin were free of tumor. So final impression was leiomyosarcoma, FNC LCC grade 2, PT2 and not assigned as per CAP protocol, soft tissue resection version 4.2.0. Now I would like to call Dr. Kaushal Singh sir, Assistant Professor in Department of Anaesthesiology, to conclude the session further.
I am here to discuss what makes this case unique. It is an exceptionally rare malignant mesenchymal tumor with the incidence of 1 per 1 lakh adult tumors. Therefore, only handful cases were reported globally. What makes this case more challenging? The location of the tumor, involving the retrohepatic part of the IVC, the hepatic veins and proximity with the vital vascular structure makes this case difficult not only for the surgical team but for the anesthesiologist team as well. Opening of 2 body cavities, abdomen and thorax for such a long time may add further difficulties to our management. The major intraoperative hemorrhage and hemodynamic instabilities were inevitable in this case. As we were discussed, the blood loss for this case is around 7 liters, but with the help of advanced hemodynamic monitoring and point of care modalities like transesophageal echocardiography, thromboelastogram and serial ABGs made our journey a bit easier. After thorough search on internet or PubMed index journals, we found only 2 case reports of such cases. In above cases, they use cardiopulmonary bypass, but in contrast, we are managed to complete this case successfully without the using of bypass, and we are fortunate to have such a highly experienced HPB surgery team led by Dr. Namish Mehta sir, whose expertise was instrumental in achieving the successful outcome of this case. And by the best of our knowledge, this is the first case of hepatic vein reimplantation of Rajasthan. This is the media coverage of our case. Take home message: this case highlights the importance of early diagnosis, meticulous perioperative planning and multidisciplinary collaboration in achieving the favorable outcome for this rare and challenging surgery. This is the video testimony.
पिछले 2 महीने से कहीं से परेशान था. मेरे लीवर में जो पार्टिकुलर कार्ड थी उससे बहुत परेशान था और मैंने 2-4 डॉक्टर्स को दिखाया था. बात की तो मुझे महात्मा गांधी के लिए सजेस्ट किया गया, निमेश सर के लिए बताया गया और जब निमेश सर से आके मिला तो मैंने मुझे बताया और देखा. मैंने सारे टेस्ट किए और फिर मैंने सर्जरी की. इसको लीवर ट्रांसप्लांट सर्जरी कहते हैं. मैंने ये बताया बहुत डिफिकल्ट.
Thanks to all the contributing department of CDS, Department of Cardiothoracic Surgery and Department of Radio Diagnosis, Department of Pathology, Department of IHBT. Thanks and regards MGUMST Management, Emeritus Chairperson Sir, Chairperson cum Chancellor Sir, Medical Director Sir, CCR Review Committee, Nursing Officer and staff members, at the last but not the least, patient and his family. Thank you.